Okay, so these are my disclosures. I'm standing here in a Siemens Symposium, so I guess I have a conflict there. But I also do some work for Janssen. We're going to move away from the breast and to breast cancer and how it kills patients. And we discuss inadequacy of clinical tools at the staging of the breast, but this inadequacy of imaging tools goes right across the paradigm until they develop metastatic disease. You know, some of the stuff that you do in the clinic is detrimental for patients and their outcomes, and I'll show you I will show you this as we go forward. So, limited tools. We have limited tools that predict the presence of metastatic disease, as a result of which we detect disease at a late stage. So here's a typical example of something that every single one of you do in the clinic every day. Patient comes along, has some back pain, has a hot spot. The SPECT scan confirms that there is a lesion. So we are very happy this patient has metastatic disease. And in fact, we spot a second lesion in the sternum. So we are all very happy. Correct? This patient has a single metastasis. You tell her, maybe we can treat this patient with some focused radiotherapy or something like that. Then you do a whole body MRI scan and you find that the patient has 15 metastases. So this is a real problem. The patient presented at a very late stage, and in fact, looking at this picture, you would say, I'm sorry, but you are not curable. You are potentially going to die from this condition. Okay, and how do I know that these are metastases? Well, I've got morphological imaging to go along with that, but what I wanted to show you was what happens to this patient when you see her multiple times. And you can see my first examination was in 2012. The latest example on this is in 2013. So this is about every 3 to 4 months. Now, what you learn when you treat people, and this patient was hormone receptor positive, and so we gave her letrozole and then exemestane as second line. What you learn is that you can get resistance that comes in very early after starting therapy. So you can already see, if you're very careful, by January 2013, that's about 8 or 9 months later, she is already developing resistance in her metastatic deposits. And in fact, the lead time to see progression on hormonal therapies is actually 6 months less than you thought. Traditionally, we think that hormonal therapies, first line, will work for 18 months. It's not true. Actually, if you monitor these patients very carefully, it's probably 6 months less. But except we don't know it. And we don't know it. Why? Because we have inadequate clinical tools. The tools that you guys use every day are inadequate for purpose. We also fail to progress patients through therapies, as a result of which they end up with large burdens of disease. And this is another problem. So let me just show you an example of this. So your clinicians are using tumor markers, right, to monitor metastatic disease. So here's a patient with metastatic disease. She has neck lymph nodes, which were painful, so that had radiotherapy. She has liver metastases. She is being treated with letrozole, and on the next scan, you can see, here's the CA-125, it's gone up, so she's progressing. But the neck is actually getting better because it's had radiotherapy, that's fine. But we can see the liver is also increasing. All right, so in this particular case, conventional tools, which in this particular instance is CA-125, reflects what's happening in the patient. Then the therapy changes. Now she gets treated with a chemotherapy, has 8 cycles. The clinician is very happy. He said, I'm very satisfied with this particular patient's progress. Her CA-125 is now, please confirm. And her neck is obviously better. And I have to ring him up and I'm saying, Dick, you know, this patient has progressed. In fact, not only has she progressed, but her volume of disease has tripled. Why did you wait 8 cycles of chemotherapy for this woman? It just doesn't make any sense. You should have done a scan much earlier on, and then we would have known that the patient was progressing, and then you could have changed at a different time. But she's now left with lots and lots of disease. And this is what I mean when I say that we fail to progress patients in a timely fashion. Now, the whole body MRI protocol isn't just about diffusion imaging. It's about morphological imaging, including imaging of the spine and of the whole body. And diffusion is just one of the sequences that we use. So we use T1s, T2s, spinal imaging, etc. But I just wanted to just focus on the diffusion component for the moment to show you this patient here who has a sarcomatoid left breast cancer. In terms of the diffusion technique, we do it in 4 blocks, 2 B values, an ADC map that's calculated with a mono-exponential fitting, and just giving you some examples of what the images would look like if you went from top to toe. Now, let's just follow what happens to this young lady over time. So she has a sarcomatoid tumor which gets removed. I was worried about a lesion here in the dorsal spine, which is why I brought her back after she's had her mastectomy. And this lesion is stable. And then she comes back and she has huge metastases. Can you see? And you can see them here. She's got lung metastases, just to give you some sort of idea. Now you'll notice her right breast has hypertrophied. If you go back, you see what happened. She decided to get pregnant. If you have a sarcomatoid breast, you decide to get pregnant, you're going to develop metastatic disease. And this is exactly what this girl has developed. Not only that, but you can see down here, this is HPOA, hypertrophic pulmonary osteoarthropathy. So she's developed the full house, and unfortunately she's now passed away. Now, not only can you see normal changes in the bone marrow, but you can see treatment-induced changes in the bone marrow. So here, for example, is somebody with metastatic breast cancer. She's been treated with letrozole. Letrozole, you know, causes osteoporosis. That increases the amount of fat in the bone marrow, and that causes the signal intensity of the diffusion sequence to go down. And here you can see how the spinal cord here, look at the visibility of the spinal cord here and here. You see that? But if you look at the T1 sequence, it's very difficult to say there is actually increased fat in the spine. And of course, you will see the opposite as well. Not only can you see hypointensity, but you can see hyperintensity also. So this is a new drug that's used for breast cancer. All of you use this in your clinic today. It's called TDM1 or Kadcyla, and this causes hyperplasia of the bone marrow. And here's a typical example of this particular woman seen on 3 occasions, and you can see how the bone marrow becomes increasingly cellular with the treatment of TDM1. Now, if you did a PET scan on this patient, you would call this progression. And in fact, people in the clinic are calling this progression. They say the bones are progressing. No, the bones are not progressing. This is bone marrow hyperplasia. You need to know the mechanism of how this occurs. I'm not going to talk to you about that today, but there is a mechanism why you get hyperplasia. Of course, the classical hyperplasia is caused by GCSF, growth colony stimulating factor. And if you use that, you will hide metastases. So you need to know that also. So here's a lady at the end of chemotherapy. Look at her bone marrow. She decides she wants to take a rest. So between January and February, it's only 6 weeks later, she takes a rest, no more chemo, and you can see how her bone marrow bounces back. Can you see that? This is regenerative hyperplasia. Then she goes on to a chemotherapy, eribulin, which is like 4th-line chemotherapy. And of course, it's extremely toxic, has to be supported by GCSF. And what happens to the metastases? The metastases disappear. And then it becomes very difficult to evaluate. And then what she did was she had another round of chemotherapy, but this time without GCSF because her blood counts were fine, and you'll see her metastases come back. So these changes in the bone marrow are very dynamic. You need to know the drugs that affect the bone marrow, how they affect cellularity, how they affect the fat fraction in a bone marrow, to be able to interpret these images. And of course, breast cancers are the patients that we all will be examining. Now, where is the evidence behind detection? Well, we know, I mean, there's meta-analysis, there's literature out there. I'll just show you a few things that they are much better. PET scans and whole body MRI scans are much better than what you are doing at the moment, which is bone scans. Please get rid of your bone scans. Look at the performance of PET scans and MRI scans compared to bone scans for bone disease. Why do you still use this technique? It doesn't make any sense, right? You do it because it's cheap. Your patients trust you with their lives, and you do something because it's cheap, not because it's the best. And this is just, for me, this is completely crazy. We also know that the performance, that there are some metastases that will be seen better on a bone scan. There will be some metastases that are definitely seen better with a bone scan. So the classical one is a densely osteoblastic metastasis. This is a woman who has a sclerotic deposit from breast cancer. Now, clearly, we can see this on a bone scan. We can see it on the CT scan, but if you did the diffusion imaging alone, you would not see it. So don't go away today saying, I should do diffusion imaging. Yes, you should do diffusion imaging, but don't forget the morphology, because the morphology clearly shows you that this is a sclerotic metastatic deposit. Okay. What about compared to PET scans? Well, in fact, it turns out that the performance is largely the same, but whole body MRI scans is better for the brain, it's better for the liver, and it's better for the bones, but PET scans are better for nodes. So this is something that you need to realize. Now, what about in terms of monitoring response? If you look at the guidelines say don't do bone scans for monitoring response in bones, right? And a lot of us don't do it, okay? The guidelines also say don't use PET scans because there's nothing that says that it improves outcomes, right? A lot of us are using PET scans, right? But most clinics do CT scans and tumor markers. And I've already shown you that these don't work very well indeed. So, for example, here's a patient who done a CT scan. Here's pre-treatment and here's post-treatment. Now, this is, as you all know, regenerative nodular hyperplasia, so-called pseudo-sclerosis. But what do we say about this metastasis looking like this at the end of treatment? Is this response? Is this progression? What is this? Here is the same vertebral body. That is the same vertebral body as that. We've got two new lesions. Should we call this disease progression? Or should we say that this is healing? So, what do the guidelines say? The guidelines say, don't look at the bones, right? So, 50% of women with metastatic disease have bone-only disease. And the guidelines say, don't use bone scans, don't use PET scans, don't look at the CT scan. So what the hell are you supposed to do? You use CA1 to 5, which is useless. So, it's crazy. The world is crazy. Now, it turns out that if you see dense bone sclerosis, that is a sign of healing. No doubt about it. But you are not allowed to use that sign if the patient is on some sort of anti-osteoclastic medication, zoledronic acid, ibandronate, denosumab, whatever you want to use, right? Now, if you are on one of those drugs, you are not allowed to use sclerosis as a response measure. Okay, so now this is more craziness that's being added to this whole situation, but we see patients like this in the clinic every day. Right? We see patients' vertebral bodies disappearing, sclerosis developing. We know these patients are getting worse. What do we do? Right? And that's why people are moving towards PET. But PET is expensive. Right. So, where does MRI come into this? Well, the thing about MRI is that it's not one sequence. It's multiple sequences, and you can weight them to look at different constituents in the bone, including in the tumor. Now, we have actually very decent criteria for disease progression, and all of you will be able to recognize these patterns or what progression should look like. But let me just show you a patient who is progressing. So progression, you have more lesions, lesions get bigger. Yeah, this is not rocket science. Okay, fine. But look at this. What does this mean? Can you see that? A ring around metastasis. Every single patient, every single one of you has seen this. What's causing that ring? You look at the literature, they call it edema, which is just complete crap. People don't know what they're talking about. They write these things in articles. Actually, it's not true. What is that ring? In fact, it turns out that ring is osteoclastic clearing or delamination of normal bone. If you knew your bone biology, and you guys know your breast biology, if you're looking after these patients, you should know your bone biology. You would realize that these rings that we see around individual metastases, this is osteoclastic clearing by tumor cells so they can move out and make these sclerotic deposits. So there's no time to talk about this, but it is there in the review articles, some of which have been written by me. Okay, now, response. What does response look like? Well, it's easy, right? Lesions get smaller. That would be response, or things become normal. Now, look at this woman. August, November, January, April. What happens between August and November? If this was the first examination, if this patient was the first time was coming to you between August and November, every single one of you would say, this patient is progressing. Please stop the treatment. Actually, the treatment carries on and she improves. What happened? What happened was edema. And that's another thing you need to realize. You need to know how your drugs work. If you kill cells with a chemotherapy, then these cells burst and then they kill cells next to them. You get this homicide effect and you get large amounts of edema. This edema results in this lowered signal on the T1 sequence. Now, if you did a diffusion sequence, actually, you will be able to say this patient is responding. And let me just show you the first two exams, just magnify that up. Okay, so here's exam 1, here's exam 2. And what you see is that the ADC goes from that to that. Easy. You look at this and you say, despite everything else, this patient is responding. So in that sense, it's like PET. It's giving you something that is biologically meaningful, which is why I'm so passionate about it. Now, if you did these sorts of examinations, be very careful about what you wish for. You may be very successful, make lots of money, but you'll be working incredibly hard. Now, this is my activity. So I started in 2008. This is the end of December last year. You can see we are doing between 70 and 100 examinations a month. The vast majority are in breast cancer. So the clinical need is in prostate cancer and in breast cancer. These are your clients. You should be doing this. Right? This is exactly what you should be doing. Now, some of you may be doing multiple myeloma. It's pretty good for that. And now it's in the multiple myeloma guidelines as of last month. There will come a time when it'll be there in the breast cancer guidelines too. So watch this space. It's coming your way. So who are the patients that you should do? Equivocal bone scans, query osteoporotic, query metastatic fracture. All of you know those indications. So here's a very typical patient of what you guys would see every day, these lesions that you see. You can do T1s, T2s, diffusions can be quite helpful. I do it for high-risk women, people who are at high risk of developing metastases. So these are the triple negatives, or these are the locally advanced HER2-positive cancers. And this is to replace what we do now, which is bone scans, which we shouldn't do, and CT scans, which are okay for lungs and the liver, but not really for the bone. Now, here's a very typical example of somebody that I did recently, has a small cancer in the left breast. She's very heavily node positive. She has nodal disease, and she has bone metastases all over the place. So a very typical patient at high risk of developing metastatic disease. I also do it for people who like triple negatives, who are at high risk of developing metastatic disease. So I don't want to expose them to a PET scan, but I want something better than what we're doing at the moment. So here's a patient who developed metastatic disease, not metastatic disease, not at the outset anyway. She developed a breast cancer while she was pregnant. She had she had adjuvant chemotherapy pre and post giving birth, and you can see between December and March she develops metastatic liver disease. So we have diagnosed metastatic disease at a very early stage. She has lots of chemotherapy, which she completely fails at, and then she dies. These are the sort of patients that we would do again and again and again. I think one of the ones that I would encourage you to do is, you know, these women who have the little things, little metastases all over in the chest, and it's really difficult to say whether a patient's getting better or worse. You know, if you do these sorts of scans, even a policeman can say this patient is getting better or worse. It's so easy. Look at this. If you look here, you can say that this patient's getting better, worse, worse, maybe the same, better, and worse. You see, it's easy. You just look at it and you can tell. Okay. Response assessments are, I've showed you several cases of response assessment, but one of the areas that I find is really useful is in this patient with a regenerative nodular hyperplasia. You know those difficult patients where you have disease that looks like this and you're trying to work out, is there cancer in there? Is there no cancer? Is this fibrosis? What the hell's going on? I think it can be very useful for this. So, for response assessment, please, please, please don't use symptoms or patient-related outcomes. By the time the patients tell you, I've got bone pain, it's too late. They've got too much disease. You need to minimize undiagnosed disease progression so you can progress them onto the next treatment. You really should look at response in a positive sense rather than in a negative sense. In other words, you want to be able to say this patient is responding and this patient is stable, this patient is not responding. And we are not doing that at the moment. So what we're doing today, every single one of you, I guarantee, in your clinics, this is what you do. This old, I put current, I'm going to cross out this current, put a big cross through that. It's old. You need to move. This is what you do. You just have two categories. The patient is progressing or not progressing. With these new technologies, there's a chance for you to completely change what you do. If you change what you do, the way you report your scans, into response, stable, and progression, compared to what you do at the moment, which is progression, no progression, you will change the way your clinicians think. If you change the way your clinicians think, maybe, and mine have, they will start to act differently. Thank you very much.
Any questions? Thank you. One question.
Yes.
We only do PET-CT or other if there are clinical signs. So you suggest then for all high risk like HER2 cancers and triple negative cancers,
yes,
to eat regularly every year?
Yeah, so the question, yeah, so there is a big issue amongst oncologists about should you follow patients for metastatic disease? Is there evidence to show that if you treat earlier, they do better? Now, that's exactly right. So if you ask them, they'll go, maybe, maybe not. So there is some controversy, but there are some, so that's the broad statement, but there is, I think, more anonymity now saying, well, actually, those patients who are likely to do worse, where you're intervening at a lower disease volume, may benefit more. Those are worth doing. So those are the HER2 locally advanced, not just all HER2, okay. Locally advanced HER2s and the triple negatives. Because in those particular patients, there probably is some benefit to an earlier intervention.
Okay. Thank you. No questions further? Then we close the session. Thank you for being here.